So hi, everyone. Welcome. My name is Amy Harrigan. I'm one of the hematologists in Halifax, Nova Scotia. And today I am the moderator for the first National Thrombosis Seminar of the 2025-2026 season. Just as a reminder, these are monthly seminars that are hosted throughout the academic year, and they feature state-of-the-art thrombosis and VTE lectures presented by both Canadian and international experts. The video recordings of the webinars are available online afterwards through the CanVector website. And as a reminder, it is a learning activity accredited by the Royal College. So I just want to give a big thank you to the members of the planning committee for this year, which I'm a part of. Next slide. Perfect. And then today's presentation, we are thrilled to have Dr. Eikelboom from McMaster University speaking to us about lessons from recent clinical studies around anticoagulation. So Dr. Eikelboom is a professor of medicine at McMaster and a senior scientist and investigator at the Population Health Research Institute. His research interests include improving the efficacy and safety of antithrombotic therapies for arterial, venous, and cardiac thrombosis. He's received uninterrupted support from many different major funding agencies over the past 3 decades and has published over more than 800 peer-reviewed articles. So without further ado, I'll turn it over to Dr. Eikelboom. Just as a reminder, there will be 10 minutes or so after the presentation for a Q&A session. So feel free to come off camera and ask your question in person, but if not, please put your questions in the Q&A box.
Well, wonderful. Thank you, Amy, and a good, I would say, afternoon or evening or maybe morning for some of you. Delighted to be here. And during the next 40 minutes or so, I'd like to discuss with you some of the lessons that we're learning from the recent clinical studies. And as a clinician researcher, I mean, many of us are clinicians and researchers. We love seeing our patients and dealing with problems. We love doing randomized trials. But one of the most intriguing and rewarding aspects of being a clinician scientist is to look carefully and critically at the work that's been done and to examine what additional lessons we can learn. For warfarin trials, there have been probably in the order, this is ChatGPT driven information, so it may not be entirely accurate, but my little search this morning, maybe 25 or 30 warfarin randomized trials in the literature, 25,000 people, maybe 30,000 people. When we think about the direct oral anticoagulant trials, we have a similar number of trials, but we have several 100,000 patients. And each of the big trials has delivered dozens of publications, and there are so many important lessons from the primary and from the secondary papers. Here are my disclosures, and I've worked with a lot of drug companies to particularly those that develop antithrombotic trials, and also I have a number of academic grants. I love to start with the timeline of anticoagulant development, because back in the first half of the last century, a series of anticoagulants were discovered by serendipity. And every time I look at this graph, I remind myself that unfractionated heparin and warfarin were in clinical use for many years before we even knew how they worked. And today, in 2025, that's almost unconscionable that we would use a drug in clinical practice and have no idea how it worked. Thankfully, we do now know reasonably how they work. They have survived the test of time. In the 80s and the 90s, we saw the introduction of advances to unfractionated heparin. And then the turn of the century, we saw this explosion, this transformative explosion of new oral anticoagulant drugs with their reversal agents. And it was almost as though we had conquered this this Everest of unmet needs in anticoagulation. I remember back in 2012 co-authoring this paper with Dr. Diener and Dr. Grange and Dr. Hack. And the take on this paper was, well, the king is dead, warfarin is dead, direct thrombin inhibitors and factor 10A inhibitors, that's the next tussle. Which of these two agents will be the final, the ultimate oral anticoagulant? Well, that was, in retrospect, rather naive, because here is a paper that I co-authored with Jeff Weitz in 2023. And the heading, believe it or not, who would have thought 10 years later, warfarin faring better? And two examples thereof, Invictus and the PROACT 10A trial. Well, with that introduction, I'm going to outline to you what I'd like to discuss in the next little while. I want to touch firstly and most importantly on the area where direct oral anticoagulants underperform, and in particular they underperform against warfarin. And there are a growing number of areas where warfarin has almost had a resurrection and remains the preferred treatment. I will then pivot and talk a little bit about bleeding, still the understudied complication of anticoagulant therapy. And finally, I'll touch on the factor 11 inhibitors. Are they indeed living up to their theoretical promise? So let's start firstly with the first area in my talk, where direct oral anticoagulants underperform and why. And by way of background to this aspect of my talk, I'll remind you that we have 5 large randomized trials, 4 of which compared directly vitamin K antagonists with direct oral anticoagulants, 70,000 plus patients in atrial fibrillation. And the big picture from 30,000 feet is that DOACs in atrial fibrillation are associated with less stroke or systemic embolism. This is the red line, DOACs, and this is an individual patient-based meta-analysis, DOACs versus warfarin. They're associated with less mortality. They're associated with less bleeding, and they're associated in relative terms with a big reduction in intracranial bleeding. So one might say, well, the data are compelling, story closed, DOACs preferred, we should move on. Well, nothing could be further from the truth. Here I've summarized where DOACs underperform. You might call these areas of DOAC failure. They're not quite failure because they still work, but they're less effective than warfarin. Specifically, areas where they're inferior, 3 compelling data sets, 1 rheumatic AF, 1 mechanical heart valves, 1 triple positive antiphospholipid antibody syndrome. I will only talk about the dark blue component here. There are areas where DOAC's efficacy is at very least uncertain. AF and obesity, or I should say AF and overweight. Patients with atrial fibrillation on a DOAC who have a breakthrough stroke, the frail elderly, and advanced kidney disease. And I've summarized here the evidence is mixed. You can have various takes on that. And then there are other areas where DOACs might be considered to be contraindicated. I'm going to start with touching on rheumatic AF and obesity AF because, strangely enough, mechanistically, they may well be linked. DOACs, and specifically rivaroxaban, was compared with warfarin in patients with rheumatic atrial fibrillation in the Invictus trial. And the primary result, the primary outcome, was this composite of stroke systemic embolism, MI, or death. 4,500 patients, very good level of follow-up, 3.1 years. The main results from Invictus, this is now 3 years old. In the red is rivaroxaban, in the blue is warfarin. At least two very surprising results. The first, the overall results, people on warfarin did better. The second, the crossover of the curves. Who would have thought that in a non-surgical trial with two anticoagulants that work pretty much immediately, we would see this crossover? Now, there are technical reasons for analyzing this study differently to the usual hazard ratio analysis using a Cox model, but let's ignore that for a moment because it doesn't change our story. But this crossover, is it the play of chance or is it real? Is it some delayed effect of warfarin that yields a long-term benefit? Let's look briefly at the results. There is the primary outcome, rivaroxaban, event rate 8.2%, VKA 6.5%, a 25% excess of events on rivaroxaban. This was almost entirely explained by an excess of mortality, a 23% excess, and you can look at the absolute difference of 1.6%. The difference here is, what, 1.7%, so almost entirely accounted for by death. Ischemic stroke, 0.4%, so some of these ischemic strokes fed into the deaths, but not by bleeding. Now, I said the difference was only in part explained by stroke. VKAs prevented 26 more ischemic strokes, but they prevented 110 more deaths. The difference in mortality when the cause-specific mortality was looked at seemed to be driven entirely by heart failure death and sudden death, sudden cardiac death. And this effect was delayed and emerged after only 18 months. How can we explain this result? Well, this is just a hypothesis, but I want to draw your attention to vitamin K and coumarins and their effects on the gamma carboxylation of vitamin K dependent coagulation proteins. And this part of the story is well described and well recognized by thrombosis physicians. And this part of the story would not seem to explain these results. But we need to remember that there are other vitamin K dependent proteins scattered throughout our tissues. And we generally ignore these because we don't really know what the significance is of these proteins, and if they're suppressed, does that explain calcification? Maybe. Do people on warfarin get osteoporosis? Well, probably not. But there's one particular protein here that I want to single out, and it's called GAS6. And I've said GAS6 so often in my career that I've almost forgotten what it means, but I won't try and say that now because I've forgotten just at this very moment. But I do know that GAS6 interacts with these TAM receptors, and these TAM receptors play a role in cardiovascular disease. In fact, protein S and GAS6 have quite a bit of homology, and they all interact with these TAM receptors. And there is a good basis for the conclusion that inhibition of TAM receptors can be beneficial for atherosclerosis, but it can also be harmful in causing vascular remodeling and resulting in hypertension. So this is one mechanism by which GAS6 can cause harm. Now, what do we know about heart failure as well as obesity? Well, there is pretty decent body of evidence that in heart failure and obesity, GAS6 levels are elevated and that they predict all-cause and cardiovascular mortality in a dose-dependent fashion. So we're seeing at least a link between a tissue-based vitamin K-dependent protein and adverse cardiovascular events. And we're seeing that warfarin over time has an impact on cardiovascular mortality, in particular in heart failure and obesity. Could this be one of the explanations? And that makes me turn to the obesity story, because quite independently of this hypothesis, which was suggested in rheumatic heart disease, we did a separate analysis, and this was run out of the Boston group, of the effects of DOACs versus warfarin according to BMI. And if we look at the data, stroke or systemic embolism, DOACs win out across the spectrum. Ischemic stroke or systemic embolism, the same cause, the same pattern. Bleeding, well, the curves converge at the highest BMI levels. Intracranial hemorrhage across the board. DOACs, less intracranial hemorrhage. But when we look at mortality, when we hit a BMI of 35 to 40, the curves cross over. Is it possible that GAS6, which is also upregulated in obesity, mediates this effect on mortality, which incidentally was driven by an excess of sudden cardiac death and heart failure death? So lesson one, and this is a mechanistic lesson. It's also an intriguing lesson. It's an unproven hypothesis driving lesson. VKA should be preferred in rheumatic heart disease, particularly with atrial fibrillation and in severe obesity. The benefits of vitamin K antagonists may be mediated by an effect on tissue-based vitamin K-dependent proteins that are pathologically elevated in these settings. And we've got work to do to further explore this story. So that's my first area of discussion, explaining where DOAC are less effective than they might be expected to be. The second, I want to look at the story of breakthrough stroke. And here I want to remind you, and this is also from the pooled analysis of the atrial fibrillation trials. I want to remind you that people who are treated with anticoagulants are at risk of breakthrough stroke. And the risk, the absolute risk, depends on the baseline risk, no surprise. But the absolute risk at 2 years can be as high as 5% in those with the highest CHA2DS2-VASc score, and even higher at 3 years. That's really quite an astonishing risk of breakthrough stroke in people who presumably are anticoagulated. Now, it's very possible that some of these people were non-adherent, that some of these people had malabsorption, that there were drug-drug interactions, and that these were interfering with DOAC exposure, not to speak of non-cardioembolic stroke, which also could occur in these people. Now, we shouldn't be surprised, even if we take out the non-adherence, the malabsorption, and the drug-drug interactions, that some people who are properly anticoagulated and adherent have suboptimal DOAC levels. This is a paper that was led by Tim DeFries and others, including Noel at McMaster, which is a careful systematic review of the evidence from the literature on usual on-treatment DOAC concentrations with apixaban and with rivaroxaban. And you will see that there's a substantial spectrum of drug levels, for example, on apixaban 2.5 and on apixaban 5 milligrams at peak and at trough. We would expect in a population that there is roughly a normal distribution of drug levels, and that therefore 1 or 2% of people would have very low levels, potentially subtherapeutic levels of DOACs, and therefore experience breakthrough events. Now, I'll come back to the approach to anticoagulation with these people, because this is one of the vexed issues for stroke physicians. What do I do with a patient who's apparently compliant, who comes in with a stroke on a DOAC? Do I just treat their stroke, and if I think they're cardioembolic, put them back on the same DOAC? Or do I switch to something? Or do I add aspirin? Or maybe do I think about doing a left atrial appendage occlusion? These are data from the LAOS 3 trial, which conclusively demonstrate that people undergoing cardiac surgery who have atrial fibrillation, who have their left atrial appendage occluded, have a 1/3 reduction in stroke. This benefit was seen irrespective of whether the patient subsequently was treated with an anticoagulant, vitamin K antagonist, closure, no closure, a DOAC, closure, no closure, or no anticoagulant. So one possible approach to these people is simply to randomize, to treat people with left atrial appendage occlusion in AF if they're at high risk of stroke, and to treat them with both the occlusion plus continuing an anticoagulant. And this strategy is currently being evaluated in a large randomized trial that is led by Jeff Healy and others here at McMaster. There's another part to this story, though. And this also comes from the combined AF analysis. And this is from Alexander Benz, who also happens to work here at McMaster. He looked at the risk of a second event or a third event in people during the randomized trials who experienced a stroke. So time 0 here is the time of stroke. And this is simply following folk for 1 to 2 years to look at their risk of recurrent stroke. And this is in people who stay on anticoagulants. At 1 year, the event rate was around 8%, and at 2 years, 11% in people who are anticoagulated. Even more intriguing, although hypothesis generating, was that people who stayed on warfarin had a much lower risk of recurrent stroke than people who stayed on a DOAC. And this fits with the hypothesis that people who have breakthrough events despite anticoagulation, people who have breakthrough events on a DOAC, have subtherapeutic levels of the DOAC and therefore should be preferentially treated with warfarin. This is a hypothesis, but I think it's a very sobering and intriguing insight into how we might treat people following stroke on a DOAC. This is the subject of a proposal that's gone to CIHR, and if funded, this will be evaluated in a randomized trial. So I want to end this part of the presentation by talking about the lessons of breakthrough strokes, both a first stroke on an anticoagulant and then also a recurrent stroke risk after a first stroke on an anticoagulant. Of course, the first question as clinicians is, when a stroke occurs on a DOAC, we've got to make sure that there's no competing mechanisms, but then we should, if we can, verify true exposure. We might switch to a mechanistically different DOAC. Aspirin doesn't really work. We could consider combining the anticoagulant with ablation or a left atrial appendage occlusion. That's the subject of a randomized trial. And maybe, if it was my brain, maybe I would just be treated with warfarin if I had a breakthrough stroke on a DOAC. To be honest, I could go on for the next long time to discuss additional areas where direct oral anticoagulants underperform and why some of the more intriguing situations include those who are frail and the frail elderly. We've done a lot of work on those folks. There is a fascinating story associated with advanced kidney disease and, of course, the antiphospholipid antibody positive patients and the mechanical heart valve patients. But in the interest of time, I want to move on to the second part of my presentation, and this will be a brief section on the story of bleeding and bleeding complications. Now, by way of reminder, bleeding is the single most common adverse event in patients treated with anticoagulants. And if we look at the data from the atrial fibrillation trials, each year, 2 to 3% of people in those trials had an ISTH-defined major bleeding events. And not only that, somewhere between 5 and 15% of patients each year had a less severe bleed. And this may have been a trivial bleed, it may have been a nosebleed, it may have been a skin bleed, but nevertheless, something that matters to patients. We also know whether the association is causal or not. We do know that there is an association between bleeding and adverse outcome, not just non-fatal adverse outcome, but fatal outcomes, including in ICH, a case fatality of 30 to 45%, and in non-ICH, a case fatality of 5 to 15%. Now, we could make the case that the outcomes after bleeds, as well as the bleeds themselves, are potentially preventable. And over the years, we've seen many trials that have studied stroke, potentially preventable, the outcomes after stroke, potentially modifiable, MI, same story, VTE. Where are our trials about bleeding? They're few and far between. For an event that is prognostically in the same ballpark in terms of predicting fatal and non-fatal outcomes as MI or stroke, why aren't we doing randomized trials of bleeding? Are we still in 2025 continuing to ignore this, the commonest adverse event, and an event that is equally important to many ischemic events? One of the limitations is, of course, that we don't know very well how to prevent bleeding and how to prevent the adverse consequences of bleeding, because we don't know what the modifiable risk factors are. Bleeding is important, not just because it leads to bad outcomes, but it's also the most important reason for not treating patients. And today in 2025, and there's a whole story to the back of this. In fact, bleeding could have taken up this whole presentation because there's so much to talk about in bleeding. But suffice it to say that somewhere in the order of 1 in 5 to 1 in 3 people in wealthy countries in 2025 who have a guideline recommended indication for anticoagulation don't get it because of fear of bleeding. And the evidence for that, well, there are clear data about the undertreatment. Of course, not in my practice, but in someone else's practice. This is how we all think, that we're the good guys. We treat everybody who should be treated, but there are bad guys out there who undertreat. I'm one of the bad guys too, just for full disclosure. Fear of bleeding is the most important reason for undertreatment. Here are some of the well-documented reasons for undertreatment, and you will see that they're dominated by issues that relate to bleeding. Physicians prioritize bleeding risk over thromboembolism risk. Despite all the publicity about this, people undertreat older, living alone, severely comorbid people, mainly because of concerns about bleeding. People undertreat those who have a history of bleeding or who might use a platelet inhibitor. And so that's the vast majority of undertreatment falls into those categories. So again, one of the problems is we don't know the modifiable risk factors for bleeding or the modifiable outcomes after bleeding. This is something that we've been working on for about a decade. And back early in 2013, 2014, after going through about 5 or 6 grant applications, we finally scored money to do a study called InterBleed. And I won't digress too much about funding agencies, but it's remarkable how you can go to one funding agency and be the #1 grant in the country. And you can go to the other funding agency and you can be triaged 5 times in a row. It's really makes one wonder how the system works. Nevertheless, despite a lot of challenges early on, we finally completed a 5,000 or an almost 5,000 patient case control study of patients with cardiovascular disease who did or did not experience bleeding that brought them into hospital or that kept them in hospital. Now, I won't go through all the methods. I just want to show you some highlights of the results. What we did is we had cast a very broad net, and we looked at the independent predictors of bleeding, and all of the usual suspects are listed here: age, sex, body weight, end organ disease, including kidney disease, medications, and then on the next slide, GI system pathologies. Now, this was focused on gastrointestinal bleeding, and I don't know whether I said that immediately. So this is only GI bleeding, because that's the single most common site of bleeding. We looked at GI pathologies and we looked at antithrombotics. We calculated adjusted odds ratio, and then we also looked at the population attributable fraction. So to put this in simple terms, this statistic provides an estimate of how much of the burden of gastrointestinal bleeding would be eliminated if we simply took that risk factor out of the equation, out of the population. If we add up the adjusted population attributable fraction for GI bleeding, we can explain only 37% of the population attributable fraction based on known bleeding, modifiable bleeding risk factors. This prediction was least in the oldest patients, where the adjusted population attributable fraction was around 25%. In younger patients, it was closer to 40%. Now, a lot more could be said about bleeding, but I want to summarize. Bleeding, common, important, understudied. We don't know much about how to prevent it or to treat it. And this is just about the risk factors for a first event. Known risk factors in this particular study focused on gastrointestinal bleeding in cardiovascular disease account for less than 50% of the population attributable fraction, and it explains even less of the risk in older people. We've got a lot of work to do on bleeding. For today, the take-home message: we have only a limited number of modifiable risk factors for bleeding, including controlling blood pressure, avoiding dual or triple therapy, using proton pump inhibitors in selected patients, minimizing alcohol, and being cautious about falls risk and iron deficiency. I'm up to about 30 minutes. I'll be very brief in this last part of my presentation. I'm turning away from DOAC failures, I'm turning away from bleeding, and I want to look critically at what we've learned about factor XI inhibitors. This is, of course, the latest generation of anticoagulants. I think we're all convinced now that we need still safer drugs, and we need drugs that can fill the gaps where these agents, these DOACs, have so far not filled the gaps. And so the ideal new anticoagulant would retain the practical advantages of DOACs that have a low potential for drug-drug interaction. They won't be renally cleared, they don't cause bleeding, and they're going to be effective where DOACs are relatively ineffective or where the use of DOACs is uncertain. Is this even realistic to consider this? Well, in theory, yes, with factor 11 inhibitors, because some of them have exactly the same practical advantages of DOACs, at least in theory. They have a low potential for drug-drug interactions. They're minimally renally cleared. And factor 11 inhibitors have a low risk of bleeding. What's their efficacy? Well, before we talk about that, very briefly, what's the rationale for targeting factor 11? There's a powerful rationale. We have epidemiologic data on people with inherited factor 11 deficiency. We have some animal experiments. And in 2015, we had an intriguing study published in the New England Journal of Medicine by Harry Buller using an antisense oligonucleotide, a little piece of genetic material that binds to the messenger RNA for factor 11 and basically stops the body from making factor 11. If you give that preoperatively, back in 2015, you give it a month before surgery, you didn't cause bleeding, but you reduced venous thrombosis. What's the mechanism? How might we explain this? Well, the best way, I think, to explain it is by a diagram such as this, which I've adapted from the European Heart Journal. When there is an extravascular injury, such as trauma, where you damage tissue, you get a lot of tissue damage, you get a big thrombin burst. That thrombin burst is by itself sufficient to drive hemostasis. When you have a plaque rupture, such as myocardial infarction, such as a large vessel stroke, you have an intravascular event that causes a modest thrombin burst. That thrombin burst by itself is not sufficient to create an obstructive thrombus. There is a necessity for amplification of thrombin generation via factor 11. And thus, if you knock off factor 11, you get less MI, you get less stroke, I should say, less venous thrombosis in the community. In the animal studies, you get less bleeding with low thrombosis rates. And in the oligonucleotide study that I talked to you about just a moment ago, it would explain why blocking factor 11 preoperatively doesn't increase bleeding, but it does prevent thrombosis. So where are we today in 2025? We have three major classes: the antisense molecules, which are given every 3 to 6 months, very slow onset and offset. A lot of work still to be done in that group. There are the monoclonal antibodies, of which abelacimab is the most advanced, and there are a bunch of small molecule inhibitors, of which milvexian and asundexian are the most advanced. Enormous promise, but here is sobering fact one. In the first and the only phase 3 randomized trial of asundexian versus apixaban, asundexian was safer than apixaban, although apixaban was remarkably safe. But asundexian was substantially less effective than apixaban for preventing stroke or systemic embolism. And here's my take on these results. If this pattern is continuing to be seen in the trials that are currently ongoing, then we will have discovered a new replacement for low-dose edoxaban. We already have this quite marvelous therapy, edoxaban, which has less bleeding than warfarin, and which is a little less effective than warfarin. We really don't need factor 11 inhibitors if that's all they're going to deliver for us, because what we need from factor 11 inhibitors, it's not just less bleeding. We need to be able to match the efficacy of existing agents. There are a lot of ongoing trials summarized here. The biggest ones, the Librexia trials. There are the oceanic trials, particularly oceanic stroke. So these first three are being done with the small molecule inhibitor milvexian, the oceanic study with asundexian, and the lilac study with, that's abelacimab. That's a typo there. That should be abelacimab. So these are the trials that are ongoing in atrial fibrillation in ACS or stroke. And then there are also these other 2 trials with abelacimab in patients with cancer VTE. So what to watch for with factor 11 inhibitors? The big picture is when you see the next trial, check out the efficacy. How good are they at preventing thromboembolism versus DOAC? If they don't win here or match the DOAC, then maybe we should just stick to low-dose edoxaban or low-dose apixaban. This is going to be a critical element of any future trial. Less bleeding, it's a foregone conclusion. They're all going to cause less bleeding, or otherwise they're going to be an also-ran for sure. If they're shown to be effective for thromboembolism prevention in AF, in ACS, in stroke, in VTE, then we should see new trials where they're evaluated versus warfarin or valve-related thrombosis and other areas where warfarin currently remains number 1. And then, of course, if this is all a success, we need to see about, do we need reversal? How do we handle them in perioperative protocols? And what do we do with those really long-acting antibodies and antisense drugs? Can we safely use them in spinals and in neurosurgery? So lots to come in 2025, 2026. In conclusion, I'm at the 40-minute mark, so probably a little too long. My apologies. The default anticoagulant is vitamin K antagonist for mechanical heart valves, for rheumatic atrial fibrillation, for antiphospholipid syndrome, and probably for people who have obesity, people who have breakthrough stroke, and the frail elderly. But let's see in those areas. DOACs are for most other patients with VTE and AF. Bleeding with currently available oral anticoagulants is very common, but usually still manageable. And we're waiting with bated breath for the next trials of drugs that target factor 11 to see whether they live up to their promise. So with that, I'm going to stop sharing, and I thank you for your attention, and I'm happy to take any questions.